Hi, my name is Riccardo Gottardi, and I'm an assistant professor at the University of Pennsylvania and at Children's Hospital of Philadelphia, and I will be talking to you today about our work on predicting the effects of rehabilitation on cartilage repair. Most of the work that I will present was actually conducted in my previous institution, the University of Pittsburgh. We focus on microfracture, which is a very common procedure that consists in the debridement of damaged cartilage and in the creation of perforation that reach the subchondral bone. And these procedures performed arthroscopically. And for this perforation, bone marrow and blood invade the cartilage space. There is a fibrin clot that forms, reaching bone marrow-derived mesenchymal stem cells that ultimately start form a cartilaginous tissue that repairs the damage. And the advantages of this procedure is that it's very simple, it's minimally invasive, it's performed arthroscopically, and it's inexpensive. So it's extremely popular as a first line of defense when there is need to repair cartilage. However, there are a number of issues. The new cartilage of this form is fibrocartilaginous, it's not hyaline cartilage. That results in poor integration with the surrounding tissues and in overall inferior mechanical properties compared to hyaline cartilage. And in fact, 25% of microfracture require reoperation just within 2 years. So the question that came to us is that, is there a way to improve the long-term outcomes? Is there any way in which we can push the repair cartilage towards a more hyaline, better integrated phenotype? And that's when we started looking at how microfracture works. And after the rehabilitation that happens after microfracture is generally focused on protecting the clot that is formed. So there's initially immobilization, and then which is followed by continuous passive motion, generally by range of motion exercises, where there is no really much load applied on the joint. Finally, there is a partial weight bearing that progressively moves on to full weight bearing. And in this whole process, the surgeon point of view is that if the patient does not come back, well, that's counted as a success. From the physical therapist point of view, if the patient does not feel pain and there is no joint stiffening, that's counted as a success. However, there is no specific focus on what is actually happening to the cartilage repair tissue. And when we think of rehabilitation, it can last up to 6 months. There is generally no consensus on the timing and magnitude of joint loading for optimal rehabilitation. And there is very little biological evidence supporting any choice of rehabilitation regimens or any sequence of different rehabilitations. And so we started to want to try to explore what is the biology behind the different loads that occur during rehabilitation. We started by taking healthy cartilage from juvenile bovine knees, getting cylinders out of the knees and creating cylindrical defects within this cartilage cylinders and filling it with the same cartilage, that's our positive control, negative control of just fibrin, and a microfracture mimic that is composed of fibrin with bone marrow-derived mesenchymal stem cells that look something like this. After that, we subjected these samples to a load just sitting in the dish. That's our negative control, compressive loading by the main system, or shear stress by the RCCS system. And the main system in compression mimics the effects of weight bearing. The shear loading that happens in the RCCS system mimics the effect of range of motion exercises, because that's primarily shear that occurs around the tissue in this reactor. This work done by Tomoya Ezeki in Pittsburgh. After 21 days, in fact, after 7, 14, and 21 days, we tested integration by a push-out test, measuring the maximum load necessary to push out the repair the repair mimic. And of course, the best outcomes were for the native cartilage, the same plug that was returned in the defect. And by far, it was much better when compression loading was applied, as you can see in this graph. Fibrin, of course, didn't improve much over time, fibrin only, but when we have bone marrow-derived MSCs in there, there started to be a progressive improvement that became statistically significant 21 day, better for compressive loading. Looking at gene expression, that's where we saw the most difference, where compared to free swelling, all these OSOX9, collagen 2, and aggrecan, these free procatabolic chondrogenic genes, were upregulated and were significantly more upregulated when compressive loading was applied. If we look at the ratio between collagen 2 and collagen 1, again, compressive loading is the one that performed the best. And this is an important indicator of how much fibrous the cartilage that is formed is versus hyaline. So it is definitely more hyaline than fibrous because it's higher expression of collagen 2. Interestingly, for the RCTS test, we also see an overexpression of metalloproteinase MMP3 and LMTS5 that degrade and remodel collagen and glycosaminoglycans. Overall, we can conclude that the rehabilitation for cartilage, when we're looking at rehabilitation for cartilage regeneration, the bone marrow-derived MSCs that are a microfracture can be modulated by different mechanical loading. And it appears that early load bearing could actually promote the formation of a more lean cartilage repair tissue. It might be preferable to start loading sooner rather than later. Having seen this, we still have the curiosity, however, of how do actually the macroscopic movement in the body relate to the microscale mechanobiologies of cells in the joint. And to explore this question, we started a collaboration with the group of Professor Bill Batazopoulos at Liverpool John Moore University. And what they did was start from X-rays of patients, use those to construct subject-specific finite element modeling of the joints, and on the same patient, measure and their movement and model from their movement and from the modeling of the joint the key parameters to extract contact forces and flexion angles. And so we could see that in a joint, what they were able to predict is what are the local loads for young, healthy male and female, for older patients that are healthy, and for older patients with clinically diagnosed osteoarthritis. And we look at the values, the older healthy patients are load a little less compared to younger patients, but the older osteoarthritic patients tend to load more. And so we focus on these two values and try to see what happens when we apply those ranges of compressive strain to tissues and how do they respond. We developed to this end a high throughput mechanical activator for cartilage engineering or cartilage studies, and which is composed of a set of pistons and that can actually apply defined strain on tissues. The system is controlled by a customized software, and a customized lead is used to maintain sterility throughout the operations. And let me show you how it works in this movie with exaggerated movement to make it more visible. You see the pistons that will come down into the multi-well plate and start the activation and oscillated loading. That's what happens. There is activations in these 6 wells, and then the system moves, and other 6 wells are mechanically activated. Then the system moves again, and other 6 wells are activated, and moves again, and the remaining 6 wells are activated. So we can sequentially activate all 24 wells, which allows for a pretty good throughput of the system. This is the lead that allows for maintaining sterility while allowing for the pistons to actually move and do their job. For this experiment, we extracted again porcine cartilage from freshly slaughtered animals. And after 48 hours of equilibration, we compared different conditions. We started from the control at 48 hours and compared to another 4 hours of unloading, the same time subjected to physiological loading or supraphysiological loading in the two ranges that we had discussed previously. And finally, we also compare it to exposure to interleukin-1 beta as a pro-inflammatory environment typical of osteoarthritis. First of all, we compared physiological loads versus unloaded samples, and very clearly, physiological loading in general improves the phenotype. Aggrecan, collagen 2, ALK5, SMAD3, TGF-beta, ID1, they're all improved markedly. Notably, collagen 10, which is an indicator of hypertrophy, doesn't change at all. So physiological loading has a positive effect in maintaining a good phenotype, in fact, in improving the phenotype in vitro, and does not appear to have any negative effect. It was very easy with the system to have an N equal 8 very rapidly. Then we compare physiological loading, supraphysiological loading, and inflammatory conditions. And since we have more conditions here, we just have an N equal 4, which was sufficient to identify a number of differences. TGF-beta1, ALK5, SMAD3, and aggrecan all are upregulated by physiological loading that you see here in green. That's the similar result as before, not unexpected. Interestingly, when we apply supraphysiological loading in red, only some of them, TGF-beta1 and ALK5, are upregulated in a similar manner, whereas SMAD3 and aggrecan are downregulated compared to physiological loading. Finally, inflammation does the same downregulation, or does not upregulate any of the good genes, but start to markedly upregulate BMP2 and metalloproteinase 13. And this way we can see the supraphysiological loading is somewhat intermediate between the effect of physiological loading and a severe inflammation. And the complex TGF-beta pathway that is generally activated positively by physiological loading, but supraphysiological loading induces an imbalance in the different elements of the pathways. In particular, it looks like that ALK5 and SMAD3 are blocked, and that slows down the production, can slow down the production of collagen 2 and aggregans. Overall, we have a robust platform to validate the effect of joint healing and repair and different rehabilitation regimens to test their effect. And this offers the potential to identify pro-regenerative loads and how they can affect tissues and cells, and consequently design body-level rehabilitation regimens that might be more effective in slowing down osteoarthritis and promote pro-healing regenerative cartilage response. And so that we can continue this collaboration between biomechanical body-level modeling and studying what happens all the way down to the tissue level, and use these two elements to actually design rehabilitative interventions. Finally, acknowledgements, all the funding sources, as I said previously, a lot of this work was conducted while at the University of Pittsburgh, and was funded in particular by Ryman Foundation, the AR3QT, and the European Union funding. And that's all. These are all the people that are part of the lab and helping the work. And I thank you for your attention.